Post-thoracic surgery pain management. Pain after surgery could be inflammatory pain, nociceptive pain, or neuropathic pain. Type of thoracotomy pain. The thoracotomy produces nociceptive tissue damage and ribs and neuropathic pain by peripheral nerves that is aggravated by respiration and coughing. Pain may further be exacerbated by the presence of chest tubes and drains. Severity and duration. Thoracotomy pain is generally severe and intense that may last for weeks. Patient may develop post-thoracotomy pain syndrome lasting months to years. 50% of the pain 50% of patients may have pain up to 1 year post-thoracotomy. Prevalence of post-thoracotomy pain may be modified with rates as low as 21% with aggressive perioperative pain management. Insufficient treatment of post-thoracotomy pain results in reduced pulmonary compliance, inability to breathe deeply or cough forcefully, and retention of secretions, leading to atelectasis and pneumonia. Prolonged immobility related to pain may lead to DVT and PE. So a plan should be developed preoperatively. So what are the choices of pain control? Administration of opioids via IV, IM or IV PCA routes. Thoracic epidural analgesia, paravertebral blocks, intercostal nerve blocks, intrapleural catheters, and cryoanalgesia has been used. The most frequently used analgesic modalities are epidural analgesia, intravenous patient control analgesia, and nurse control intravenous opioid infusion. Systemic analgesic. The systemic analgesics are the main alternative to more invasive techniques. Intravenous patient controlled opioid is the main component of systemic analgesia. Systemic opioid can be associated with significant side effects, which has prompted the search for alternative systemic medication. With opioids alone, IM or IV, the analgesia may be marginal and side effects intolerable like nausea, vomiting, sedation. Thus, the need for synergy, choosing the drug class that will overlap for analgesia but not for the side effects. Drug classes that fit these requirements are as follows: mu antagonist opioids, cyclooxygenase inhibitor, alpha-2 antagonist, nitric oxide synthase inhibitors, and methyl D-aspartate receptor blocker. Non-steroidal anti-inflammatory drugs continue to be an important adjunct to opioid analgesia. Namisulide 90 mg orally twice daily does not influence the postoperative morphine requirement after major chest surgery. Adding ketamine to morphine for patient control analgesia after thoracic surgery influences of morphine consumption, respiratory function, and nocturnal desaturation. Intrathecal morphine to patient controlled administration PCA. Morphine improves the post-thoracotomy pain relief and respiratory function. Tramadol administered by continuous intravenous infusion may be as effective as thoracic epidural morphine. The mainstay of postoperative pain, there is a good evidence that the aggressive pain control in the form of epidural analgesia with local anesthesia following the thoracic surgery improves the pulmonary function, reduces the morbidity, and reduces the length of stay in intensive care. Epidural analgesia have some side effects from technique: dural puncture, epidural hematomas, epidural abscess, nerve root trauma. From LA, hypotension, paresthesias, motor weakness. From opioid, delay in respiratory depression, urinary retention, and pruritus. Effective postoperative pain control may be achieved by delivering an opioid or a combination of an opioid and local anesthetics into the thoracic epidural space. Postoperative patients can consume 50 to 100 mg of IV morphine during the first 24 hours of postoperatively when given by PCA. In comparison, epidural doses of 5 mg of morphine can provide postoperative analgesia for 12 to 24 hours. The commonly used opioid local anesthetic mixtures reported include fentanyl bupivacaine, morphine bupivacaine, and fentanyl ropivacaine. Levobupivacaine is an isomer of bupivacaine with decreased cardiotoxicity alone and in conjunction with opiates. Ropivacaine has a similar onset and duration of action to bupivacaine, but it has enhanced safety profile due to decreased cardiotoxicity and a less profound motor blockade than either bupivacaine or levobupivacaine. Ropivacaine fentanyl thoracic epidural analgesia after thoracotomy is comparable to bupivacaine fentanyl analgesia in terms of pain control and side effect. Thoracic lumbar epidurals, LA versus LA combined with opiates. Opiate alone, what type of opiates? No significant difference in analgesia and pulmonary functions were seen. However, less opioid was required in patients receiving thoracic epidural analgesia. Patients who receive epidural bupivacaine has a reduced incidence of SVT when compared with patients who only receive epidural opiates. The reduction was due to a reduced parasympathetic tone, and this reduction could have a significant impact on postoperative cardiac morbidity and thoracotomy. Paravertebral block. Single shock of continuous techniques are also useful in providing postoperative analgesia following the thoracic surgical procedure. Continuous paravertebral blocks provide a superior postoperative analgesia when compared to single shot technique. Paravertebral block and epidural analgesia provide a comparable pain relief after thoracic surgery, but paravertebral block has a better side effect profile and is associated with reduction in pulmonary complications. Paravertebral block can be recommended after major surgery. Intraoperative paravertebral catheter insertion provides comparable pain relief to the thoracic epidural catheters. Ease of insertion make it an alternative route for epidural insertion. Intercostal nerve block. The sustained benefit can be obtained by the use of local anesthetic infusion into the intercostal catheters placed under the direct vision above and below the incision prior to the wound closure. Extrapleural intercostal block. It has been demonstrated radiologically that the site of action of local anesthetic via the extrapleural intercostal catheter is primarily via the paravertebral space. The extrapleural intercostal analgesia might be a valuable alternative to the thoracic epidural analgesia for pain control and thoracotomy and should be particularly considered in the patients who do not qualify for thoracic epidural analgesia. Thoracic epidural versus intercostal nerve catheter plus patient control analgesia, and there is a randomized study which was published. So in conclusion, the satisfactory pain control was achieved after thoracotomy using the EPI or IC and PCA. The IC and PCA achieved equivalent pain control as compared to EPI. ICN was placed by the surgeon with no delays in surgery, decreased requirement of a Foley catheter duration. Extrapleural intercostal catheter versus thoracic epipleural for thoracotomy pain. This study is currently recruiting participants. Information provided by Virginia Commonwealth University. Cryoanalgesia. Cryoanalgesia of intercostal nerves performed prior to wound closure produces intercostal blockade lasting for several months. Despite the theoretical attractions, it is in one of the few controlled trials of technique, it did not produce improved pain scores on respiratory function. In addition, the cryoanalgesia may lead to development of intercostal neuralgia. Cryoanalgesia be considered as a simple, inexpensive, long-term form of post-thoracotomy pain relief which does not cause any long-term histological damage to intercostal nerve. Analgesic plan should start preoperatively. Multimodal approach by modulating different pain pathways, and mid-thoracic epidurals are the standard of analgesia. Extradural intercostals and paravertebral catheters are gaining the popularity and excellent alternative. Thank you.